Good morning, Rob. Glad to be back here again.
Good morning, Mark.
How are you?
I'm pretty good.
Good.
Pretty good. Busy summer. Hot. Too hot.
So what we do here is for our patients, what we've been doing for the last several months, over a year now, is conversations.
I feel like since COVID.
And it's basically based on information that our patients feed to us. So we appreciate your questions, whether it's in the dental office or through emails, because those are topics that we like to choose to help with our patients. So one topic that's trending in dentistry now I want to jump into, and you can help me with this, is AI, artificial intelligence.
It's trending everywhere, right? Everything's AI now.
Just from an individual using chat to talk. I have an example. I'll tell you a story, and I want you to get into the algorithms of AI. A patient of mine said over the weekend, I couldn't get in touch with you. I was biting on something and I had pain, and then it was sensitive when I would drink a cup of coffee. He goes, so I put into chat, hey, I have pain when I bite and some sensitivity to hot. We're not getting into the whole story. The chat told them you possibly have a cavity or a cracked tooth, and the hot sensitivity is probably nerve damage. So it was pretty accurate without seeing a dentist and taking an x-ray.
Pretty good, yeah.
So you can imagine how it's helping us in our office.
It'll help us do a lot of things. It won't do everything for us. I mean, I think the confusion around everything with AI right now is it's going to be replacing. I don't think it's going to be replacing a lot of things. The one thing it'll probably replace in medicine is radiologists, right? Reading images is the one thing that it will mostly replace. And that's the area in dentistry that it's moving the fastest. There's a handful of companies that offer the assistance of evaluating radiographs. A radiograph is simply an image. So it can read the pixels and can read trends and try to learn. The one thing is it'll highlight areas for us to interpret and then confirm or deny if it's a problem.
So what have we been doing so far? We teamed up with Grin, which is a company where we put a little scope on our iPhone.
A camera, yeah, on your phone.
And we're able to take images of the patients. A lot of you patients might have seen this already, that we're doing it in the office, and basically we're collecting data. And how's the algorithm using this data?
It's again using a photograph to analyze changes in the photograph to try to interpret the data. Exactly that. And of course, and when we report back, if it's a positive or negative on what it read, it helps to hone in and make it more specific.
So if we have multiple scans on a patient throughout a period of time, you can compare them.
Right, that's the next thing, right? Analysis over time is where it's going to be really useful. And it's not there yet simply. So we take two optical types of pieces of data of our patients, like Mark said. It's a single photograph, which is this Grin scan. It's a video that is then turned into still photographs that is then interpreted. That's one thing. It's two-dimensional. The other thing that we do for a lot of our patients, depending on the workflow and what patients need, is an optical impression. That's a three-dimensional scan. That's capturing more of the topography of your mouth, not so much the photograph of your mouth. But these two things can interpret changes over time. We're not quite there where it's the workflow exists that we can take multiple piece of information, simply put it, overlay with our software.
Stitch it all together. Yeah.
Our optical lives in one place in terms of optical impressions because of the type of file it is. And then, of course, the radiographs live on another place because of the type of file it is. So things are a little segregated right now, but the future is to combine the information and read it and analyze changes over time will give us the ability to know how to treat things better. And not to treat it, right? Sometimes we'll have a patient look at a radiograph and say, is there a change? Is there not? The problem with that is that it's somewhat inconsistent.
It's a different angle or a different
angle.
Assistant taking the x-ray.
And so it's hard to get it consistent. Yeah. So it's hard to really analyze the two-dimensional rendering of this three-dimensional object. But with time, we'll get there. And I think it's going to make dentistry more specific or less false negatives.
I think there's so much more for the future of this also. You just think how it's being used with Invisalign now, the approach how orthodontics have changed. So they feed to the computer, and the computer is digitally moving the teeth into proper position over a small amount of time, and the patient switches trays, and through a process of 6 months to a year and a half, it'll improve the patient's occlusion, orthodontics, all done digitally.
I think what it'll really do, and I don't mean this the wrong way, but it's going to bring the lower level of healthcare, at least dentistry, higher. It'll raise the standard for the people that are maybe, too busy to focus or lower level practices. It'll help get them to a higher level than where they are now.
It's just like a 3D X-ray that we do now is more of a standard of care. How about the future of robotic surgery?
Right now, it's used commonly in implant placement. There's a couple different executions.
Not too commonly. Some of the top guys are using it and experimenting with it, but it's working.
Right.
It's approved and it's in the field.
It's mostly used for larger situations. There's a couple different ways to execute that information. You'll take CAT scan, you'll take, again, an optical impression. You'll then digitally plan the surgery and you'll 3D print things, or not at all. There's a kind of like a GPS robotics that'll be a live location of the patient and where the implant's going in, where the bone is. So there's a couple of ways of executing this, and eventually AI will be able to understand where to put the implant in the best location. So I think that's a great segue into, we were talking about with a handful of patients recently about implants and implant complications, things to be mindful of. And that exactly ties into what we were talking about.
Yeah. So before we get into it, so AI is going to probably minimize implant complications and probably better educate the patient to make the right choices, right? By gathering all this data together, easy to educate the patient, to explain what we need to do for treatment.
It's worth pausing and saying, I just spoke to a patient, right? And who's about to get his first implant. And we just went through, and an implant replaces the root of the tooth. So the tooth comes out, you have a failed tooth, and then there's a volume of bone and there's a density of bone. The implant goes into the bone. The implant replaces just the root of the tooth. And then after healing, we can make a tooth on the implant. So the factors are the tooth comes out, there's some bone graft or not. Typically there is. Step 1. Step 2 is the implant goes in, replaces the root alone. There's no tooth on it. That has to heal about 3-4 months, 5 months in between each step. And then once the implant is healed, we can put a tooth on the implant. That's the process for one tooth, or there are multiple tooth solutions and different things.
So you and I are not doing that surgical part. We're doing the restorative part, but we're very involved in planning the surgical aspect. And I think a lot of implant failures are related to surgical aspects. I mean, we can have 10 or 12 topics we can speak about implant failures, from screw loosening, from this and that, and we can get into all of them. But some of the complications that we see in implants could be related to the surgical technique. Not just the choice of surgeon, bad bone, bad angulation, and all of this can be resolved. Well, some of it can be resolved by doing proper imaging prior to placing implants, by doing a 3D scan, by making a surgical guide to make sure the implant is in the proper area where there's enough bone.
For tough spaces when it is, right?
Yeah.
A really good surgeon doesn't need that in a common place. But sometimes a surgical guide or navigated.
Describe what you mean by a common place.
Great. So what we're evaluating when we take 3-dimensional scan of a missing tooth, right? We're looking at the bone. So first thing we're looking at is the width of the bone. That's the first thing we look at every time. And then the depth, right? The volume of the bone. Typically, the density of the bone in your jawbone is not the biggest issue most of the time in most patients. But we do look at that. So volume and density. And then we're looking for all the different landmarks. We're looking at the adjacent teeth to see where the roots are and the ligaments. We're looking at nerve and blood vessels. On your lower jaw, you have a nerve that is beyond the implant. It has to be beyond this, should be beyond the implant.
Hopefully it is.
So the depth there, how much space you have, you can't get too close to that. There's also a lingual artery running around. You can see it on some CAT scans. So if you pierce that, that could be a major complication. That's like the number one thing of a complication. And then purely is how much wiggle room do you have to angulate that implant? And essentially, is it a very narrow field, or do you have options of where you can place that? So we're also looking at comparatively the teeth next to the space and opposing teeth, right? So functionally, where is that implant going to be going with the tooth above it or below it? Number one. So is it in the same spectrum or not? Like, is it the same angulation axis or not? Is that a problem if it's not? Debatable. Probably not so much if large angulation. But then it comes down to the hygiene ability. So we're looking at the teeth adjacent to it to make sure it's in the right plane, also making sure it's not too close or too far. I like that you brought that up first, that the placement of the implant, where it goes, is so important. The other part of it is what manufacturer, what type of implant is being used for that solution. We have lots of options. I'll jump into a story real quick. I had a patient, younger patient, who's had a lot of dental disease early in her life, and she's lost some teeth, some inflammatory issues. And so she had a surgeon that I don't work with, we don't work with. They're outside of the city, so she commutes in for us. And so I had a phone call with this surgeon. He took the tooth out, did graft, did okay job, it's all right. We had a conversation about what type of implant they were going to use when the healing was finished. And he said to me, well, I only put this one company in. I only place that. And I said, well, do you do company B and C? And he goes, no, I only do A. I only do this company that I place. I place it my whole career. That's all I do. So from our perspective,
Is it a system that you're not?
it was Nobel Biocare.
Okay. So,
Yeah. I mean, it's something that we don't use so commonly in our
Right,
practice right now.
right.
It's one of the most popular implants, but it's something that we scientifically and engineering standpoint, we don't use commonly in our practice because we feel there are better options.
Correct.
This led me to the conversation with the patient of, well, if it's a one solution fits all patients type of approach, I just think there's a little bit of a problem there maybe, because I don't think one solution fits all patients. I think there are different types of designs from implants. And unfortunately, there are different designs. I feel like maybe AI will figure out that there's one
Just
implant.
to make one implant would be easier for
There's
us.
one implant that is more successful by a few percentage, but maybe there's not. Maybe they're equal. But so the decision of this person to only put in one type of implant and not deviate, I wonder what other decisions they're making that are like that. Very narrow focus.
And why only one implant, right? If they're cutting corners for that, where else are they cutting corners?
Right. Like, where else? And so, and then they said to me, like, well, I can call a few reps and see what I can get some supplies to place the other implant if you want. I like, no way. The conversation was that I actually put some pressure on this patient to go to one of the surgeons that we work with, was the end result. Because we're going to help maintain your implant with you and your teeth for the rest of your life, essentially, right? Our lives together. It's both of our problems. The surgeon puts the implant in, and not to downplay their role in it because they're so critical, but they put the implant in and then they hand the patient off to us. Their relationship with you is finished. Now we have to maintain it. So the surgeon and where the implant goes in is so important, like you said.
And we said there are some solutions that are simpler, but I feel most surgeons that we're working with are still scanning almost every patient for an implant placement.
Our surgeons do.
Yeah. I've had a patient, an anterior implant placed, and patient was having pain on the tooth next to it, had a root canal treated on that tooth next to it, didn't help, found out that the implant was in communication, it was touching the root of the tooth, and that easily could have been avoided on the x-ray. There has to be a certain amount of space between the implant, 1.5 millimeters of bone between the implant and the natural tooth. So this person had to have the tooth taken out. The implant was fine because of improper placement.
Yeah, it affected. It's funny. A few days ago, Dr. Fisher at our practice was taking a CAT scan on a patient who had seemed to have an infection on the 2-dimensional x-ray. It seemed a little interesting, so they took a 3-dimensional scan, and the patient had 3 implants in a row. The one implant that was placed by, it was like 6-7 years ago by a different surgeon, was half out of the bone. It was out laterally, right? So if you're taking a single radiograph, it looks like you can't appreciate the lateral position closer or further from the x-ray. But the 3-dimensional x-ray showed that it was half out of the bone. So what happened was, over the course of 4 or 5 years, bacteria was able to penetrate that space and infect the implant. So the implant's coming out.
So speaking of bacteria, let's talk about oral hygiene and a term called peri-implantitis, and how our patient's hygiene will and will not affect the implants, and how important that is. I guess we can tie that into inflammation, and maybe even medical history could be tied into that, right? You spoke yesterday to me about uncontrolled diabetes, and that, along with bad hygiene, how that can affect an implant. Yeah,
so let's assume that an implant was placed in the right position, or the bone only allowed it to be placed in a position. So the implant is the implant now, and everything's stable and healthy. The surgeon and us did
the best we could.
Did the most important thing. Yeah. We have some responsibility in how we shape the tooth and the material we use and how we make it, of course. And then it's the patient's responsibility, and hygiene is critical. And how you clean your implant is different than how you clean your teeth, because there's no ligament. It's a different shaped object, right? You have a 10 to 12 millimeter molar being replaced by a 5 millimeter implant. So just volumetrically, again, the shape of it, the tooth is the same size, but the base of it is not. The foundation is. So you have to floss there differently.
Like a lollipop, right?
Yeah,
like a lollipop is a good example, right? As opposed to a natural tooth.
Right, natural tooth is more straight.
Right, less of an undercut.
There's not that kind of vertical to horizontal component, that angular component, like an arc. So you have to floss differently. So that arc is
easy to get bacteria to sit in there.
Right. So the two complications that happen there, right? Like Mark said, peri-implantitis, the gum tissue and bone can get infected and start receding away from the implant, just like it could your tooth. And then one thing we see on patients a lot are cavities on the adjacent tooth.
Big problem.
So that's one of the complications we see with implants, is the hygiene is inadequate or hard to clean.
Now, I find there's 2 reasons for that decay on the adjacent tooth. One is what you described as that conical shape of the implant, where the bacteria sits in between there and the natural tooth. And also the fact that implants do not move once they're integrated in the bone, and our mouth is constantly changing and moving. So our natural teeth will shift, and there'll be spaces sometimes that open up between the implant and the adjacent tooth.
Right. So the mesial drift, typically this will happen in front of the implant, not behind. There'll be a drift of your teeth, crowding will occur, natural progression, the teeth move forward, and in a full dentition, the tooth would have moved with the other teeth, but since it's an implant, it stays there. A space opens up, and then foods get caught.
Part of the reason why we recommend the mouth guard or hard guard after implant placement to help keep the teeth in position. Have you done like an anterior implant crown, and a few years later you look at the incisal edges and they're not even, and you know you didn't leave it like that, and the implant didn't move, so the natural tooth can either extrude or intrude over time.
You know, so it's something we talked about, you and I have discussed about retainers for patients with implants. And I spoke with one of the orthodontists we work with. They said, you know, why is this not a standard of care throughout the profession? Because logically it makes sense, but for plenty of patients, you don't need it. Most patients, you do not need a retainer, but there's a percentage, we don't have the actual number, but for a percentage of patients, the space opens up, things move. And so at what point do you think about a retainer? And, you know, the orthodontic community doesn't seem to have position on this.
Maybe AI will help us in the future to help determine whose teeth are shifting, whose aren't. Because you're right. Sometimes you'll see 5 years later, there's no changes. And other patients a year later, the teeth have shifted.
It'll make, yeah, maybe.
Which brings you into bruxism and implants, and you can get into more complications with grinding.
Right. So people who grind their teeth, why did you lose that tooth to begin with? Was it because of decay? Was it because of gum disease, or did you fracture the tooth? I think it's important to consider that, right? When you get a replacement, whether it's a filling or crown or an implant, what happened that lends you to need that solution, and how can we prevent it or lessen it from happening in the future? So people who grind their teeth, like Mark mentioned, night guards are a good idea if you're grinding your teeth. We're working on the next few months, we'll have it by January, as a way that you can monitor if you're currently grinding. We're exploring a few options right now. In the next few months, I'll give you a little peek. Mark and I and a few of our team members are working very, very hard to look at all the different ways we can screen for the diseases that can happen. We're trying to uptick the level of prevention we have for our patients. And so our goal is, and our deadline is to have that all ready for January. And one of the things is, are you grinding? We have this conversation daily with the patient because there's history of grinding on their teeth that we can see from a clinical exam. There's signs of wear and tear that is accelerated beyond their age. I listened to a podcast this morning, and they were talking about biological tests. Like, you can take your blood, send it, and they tell you what your biological age is, right? Yeah. Which is kind of bull, because like their example is, well, if it says if you're 60 and you send it in and it says you're 30, well, the average 30-year-old is going to live 60 years. Even if your test says you're 30, you're not living to 120.
Correct.
So it's kind of like a useless fake test because it's not actually
Is
accurate.
it giving you that 30-year gap?
It'll say that, yeah. Yeah. Because the example in the person in the podcast, it said he was like 25 years younger. And he's like, I'm not living 25 more years. So the thing is, on a clinical exam, we can actually look at you, and let's say you're 60, and we can look at your teeth, and sometimes compared to the average 60-year-old, your teeth look older. We should develop a test for that.
Yeah, my Aura Ring is now doing that with a cardiovascular score. It says you're 2 years behind your cardiovascular age.
That's great. That's cool.
I'll take that.
But so we're working on having something that you can easily use to see if you are currently grinding or not.
Or clenching.
Yeah, so different things, right?
Clenching's going to possibly fracture a tooth or an implant also.
Yeah, you have a better chance your partner or someone sharing the bed with you knowing if you're grinding because of the noise, the simple noise, the kind of little squeaking of your salivary glands shut off, your teeth are dry, grinding together. It makes like a little squeaking noise. But we're trying to figure out how you can do that. So if you are grinding, having an implant or not, a night guard is a really great example of protecting you from grinding. The other thing that we talk about with patients is their age, right? How old you are doesn't directly affect the implant outcome, but health-wise, your immune system is definitely affected there. So the timing of replacing a tooth or treating things is an interesting conversation itself, and maybe we'll do that at our next.
It's a big topic, yeah. I mean, you can tie that into implants also, right? Sometimes
so
we don't recommend
implants. We have 18-year-olds that are missing a tooth.
And we know that mouth is going to be changing and growing and developing. The wisdom teeth aren't even fully developed yet.
We have healthy 86-year-olds that are missing a tooth, and the conversation is to replace it.
It has to do with health. It's exactly what you said. Not as much age as it does to do with the health of the patient, right? You have 86-year-olds placing implants. I have 70-year-olds that don't want to place implants because of their health.
The other thing with bruxism, just to jump back in that, is once the implant is placed, let's say you have perfect hygiene, the implant is there, so the implant replaces the root of the tooth, the restoration is there in the implant, held together by a screw. There can be complications of the screw loosening in people who grind, right? They can break the crown. I have had patients break implants in my almost 15 years of practice. It's happened less than 5 times that I know of, that I've tracked.
So do you feel that was related to clenching,
Yes.
grinding?
Yes.
Or also, okay, because
Yes.
there could be a surgical involvement also.
Not with that. He broke a tooth, snapped it in half from grinding and clenching, then had an implant, broke the restoration first, then broke the implant, had the implant taken out, had another implant put in, and we decided to make a titanium abutment with a gold crown, just like you were showing me yesterday. So we did an Atlantis abutment and then a gold crown over that to the softest material we have.
Breaking the screw is a problem, but not as bad as splitting the implant. So the screw is the weaker link. We would prefer the screw to break than the implant to split.
The other thing is that depending on how your implant restoration was made, you had a patient this week, a new patient who came in with the abutment, which is the piece that goes onto the implant.
And she lost the crown.
She had no crown.
She had no crown.
Just no crown.
Because it was a cementable crown.
Right. So there's 2 ways to restore an implant. You either screw the crown into the implant as kind of one apparatus, abutment crown, one piece made.
The abutment is made and the crown is made and they assemble together.
Right. We assemble them together, screw that in, or this intermediate piece, an abutment, is put onto the implant, and then just like you would a tooth, you cement it on.
Seems a little sloppier cementing it if we don't have to, if we could just rely on a torquing and a screw.
You know, I think our next talk we should go into also, which is related to this, is bisphosphonates. I know we talk about this constantly with patients, and there's an incredible amount of confusion. I think there's a amount of confusion from the patient standpoint and the practitioner standpoint. I think the whole medical dental community is a little unsure exactly what to do around this.
Yeah, and they're scaring the patients with the warnings on them.
They are scaring the patients.
Yeah. That we can dive into that, I don't know, later and get into different types of bisphosphonates because they could be responsible for implant failure.
They could influence it.
I have not seen any. And the surgeons I've worked with, I've asked them, they have not seen any failures due to that, but it's on the radar and it's been talked about.
So bisphosphonate is used for more women than men. It's to treat osteoporosis, osteopenia. A lot of strong studies show that it's worth taking bisphosphonates. Patients ask us a lot. The one thing is that your endocrinologist will tell you that you should have a proper dental exam prior to starting to make sure there's no dental disease. The bisphosphonate slows the metabolism of your bone from breaking and building it. It slows down the cells that break down your bone. That's what it does. And so sometimes there could be a complication in your jaw because it doesn't clean up dead bone cells.
Okay, so Rob, let's explain the difference between an osteoclast and an osteoblast.
Right, so an osteoblast is building bone, osteoclast is breaking bone. They work together.
They work at the same time.
They work together, right? Yeah, so the bone has to be broken down, cleaned out to then be rebuilt. So when an implant goes in, you're mechanically putting pressure on cells. So you get pressure necrosis, the cells that are touching the implant die. And then you're also getting some heat generated from the drilling in the bone. So you get some heat necrosis, which is the normal physiology.
So how does that, is it similar to orthodontic movement? But there's no heat generated.
Right, that's pressure necrosis. That is similar in a sense that you get some pressure changing. It's a little gentler with orthodontics.
I think so.
Than like just,
but you're still getting the osteoblast activity to
you
fill
still
in
get
the bone.
Exactly physiologically the same turnover of the cells, cleaning up the dead cells and building new cells. So there is a little bit of a question around patients on bisphosphonates taking out teeth, putting implants in. The dental profession tries to stay away from that on some level. And, you know, we have a patient who's an endocrinologist at HSS, one of the most well-respected people in medicine right now around this. And we've had long conversations with them about this. And they think it's overstated in the literature, overstated in the way that people are practicing, that it's actually something that not be afraid of so much.
Correct.
And I know that we haven't seen it much in our practice.
No, not at all. No, not at all. There are a lot of patients that are on these meds.
Seen it once in my residency on an immunocompromised individual. I'm in a hospital setting, which is very different than luckily where we are in our practice. And then I have one patient recently that has been on these medications that she had surgery. And when she was being anesthetized by the anesthesiologist, they caused some trauma inside her mouth on the lingual of her mandible. And she got hit it. Like they hit it and caused a bruise.
Was that my patient? I've seen the same thing.
That was my patient. Yeah.
And it wouldn't heal.
It's been 4 or 5 months.
Yeah.
There's still a little ulceration there, and the bone actually debonded, like it broke loose. It's a little piece of bone, and it's just sitting there. It's not being turned over. Sent to an oral surgeon. We took a CAT scan of it. You can visualize. It's actually a really cool CAT. For us, it's a very cool CAT scan because you can visualize this island of bone. So it's good. It's not scary. I was getting a little scared. This ulcerated lesion with oral cancer. It was like not healing. It was. So we said, let's take another image of it. And sure enough, we saw the bone there. I had her for a handful of recalls to just see if it was healing. Healed a little bit. Had her doing alcohol-free chlorhexidine on it. Sent her to an oral surgeon. And the decision was we're just going to watch it because it is getting a little better over time. I thought maybe he would go in and remove the bone, but he decided that it might have more, the actual site, since it was ulcerated, might have a higher complication.
The problem is to close that area.
Exactly.
You have to remove it because the tissue is
Exactly.
paper thin on the inside.
Exactly. And so there are possible complications around dental implants. Dental implants are in the high 90% successful, but we wanted to spend a little moment dipping into this because we want to put on the radar of people that if things are done right, in the best conditions, we manage your medical complications, we physically put the implant in the right place using the right implant, we make the proper restoration, the proper way, the proper material, we then engage with you on how to clean that implant, and then you have the right environment, you're not grinding too much, you're protecting it or retaining your teeth.
It all ties together.
It can be something that is the most successful treatment you have in your mouth. But we're spending a minute just to think about what we can manage, because that's what we do all day long. Like, what can we control? What can we manage? So if we can manage and control it, let's do it.
We have to go to work now.
All right. Well, let us know what other ideas you have for us, what other things you're thinking about. Thank you for your trust, as always, and your time with us.
Let's go take care of our patients. Please feed us with some more questions for our next month's session. Funny, to wrap it up, a patient of mine came to me. He's like, I love watching your show. I'm like, we don't have a show. We have a little talk. He's like, no, you guys show. It's pretty good.
And just last thing I'll say.
It's not a show. We're here to help you.
If you made it this far, if you watch the whole thing, we're in this new space here that we it's a small office that we built down the hall from our current space. So we're literally just about 40 feet from the office right now, down the hall in a little office space that we put out here. So come check it out if you're here. Yeah.
Enjoy your day. Thanks, Rob. Thank you.
Thank you, Mark.